Hello, welcome to the Catalyst Podcast. I'm your host, Charles Epstein. I am delighted and honored to welcome to these microphones Mr. William L. White, a true giant in the field of addiction and recovery. I've been wanting to shorten my intros on these pods, but I'm going to have to put that on hold for this, as Bill's work is uncontainable within just 2 or 3 sentences. So, if you'll indulge me for a moment, Bill is an Emeritus Senior Research Consultant at Chestnut Health Systems, Lighthouse Institute, and past chair of the Board of Recovery Communities United. Bill has a master's degree in addiction studies and has worked full-time in the addiction field since 1969. He has authored or co-authored more than 400 articles, monographs, research reports, and book chapters, and 20 books. His book, Slaying the Dragon, The History of Addiction Treatment and Recovery in America, received the McGovern Family Foundation Award for the best book on addiction recovery. Bill was featured in the Bill Moyers PBS special, Close to Home, Addiction in America, and Showtime's documentary, Smoking, Drinking, and Drugging in the 20th Century. His sustained contributions to the field have been acknowledged by awards from the National Association of Addiction Treatment Providers, the National Council of Alcoholism and Drug Dependence, NAADAC, the Association of Addiction Professionals, the American Society of Addiction Medicine, and the Native American Wellbriety Movement. I'm going to need to come up for some air, Bill. In a fitting tribute to his life's work, Chestnut and the Lighthouse Institute are building an online library repository of the more than 20,000 books, articles, and materials Bill has collected over the years. Bill, welcome.
Thank you, Charles.
Did I miss anything?
No, it's more than enough.
Yeah. Well, when the repository library is live, people I'm sure could tap into that voluminous work we alluded to. So you're based, I'm based, as you know, on the East Coast of Florida. I think you're based on the other coast, yes?
Yes, on the West Coast.
Yes, we are recording on a day that most of the nation is experiencing highly frosty weather. I know, Bill, I'm a bad person for saying this, but I have to say it gives me some pleasure, particularly considering all the abuse we take as Floridians. I don't know if you share that feeling. But how long have you been down here?
Since 2003.
Oh, okay. And by way of, where were you previously?
Illinois.
Ah, yes. Well, of course, Chestnut territory, Lighthouse territory.
Yes.
By the way, do you think the impact of storm systems that hit the west coast of Florida will be affected now that they'll be coming from the Gulf of America as opposed to the Gulf of Mexico, Bill? You don't have to answer that. You don't have to answer
I'm
that.
not sure.
Okay, good answer. Anyway, look, I really do appreciate you taking the time to speak with us today. I and many of us, Chestnut Lighthouse, have been looking forward to this. So thanks so much, Bill. You've been at this since 1969, as I mentioned in the intro. Let me ask, how did you get into this field? Who or what inspired you? What drew you to it?
I entered the field in the 1960s when almost all of us who worked in the area at that time were either in personal or family recovery. There was still a lot of stigma, not just to people with alcohol and drug problems, but also people who chose to work with them. So there was always this nagging question of, why would you want to work with those people, among your professional peers of psychiatrists, psychologists, social workers, the few who would choose to venture into this arena. And most communities at that time really didn't have any specialized services for addiction. Most people with severe alcohol and drug problems were in the back wards of aging state psychiatric hospitals or in the drunk tanks of local jails. So as an early outreach worker in those years, that's where I spent a lot of my time. I screened people in the back wards of these state hospitals, made daily rounds in the drunk tanks of 2 city jails. And they were really despicable places. I mean, places of just incredible indignity and depravity, to to be some of the worst days of your life in those places was just horrific. And there was a whole generation of advocates that came before me in the 40s, 50s, and 60s that really set the stage for the rise of modern addiction treatment. And some of those early advocates really inspired me. And I thought as a very young man at that point that this would be a very worthwhile, fulfilling way to spend a life if I could get rid of the drug tanks and those back wards. And so I entered that field, and here I am 50 some years later, and it has been a deeply fulfilling life.
You know, it's interesting. When I asked you the question, the first response you had was referring to the stigma that attaches to people who are suffering from addiction or providing treatment. But it sounds like the stigma was partly what attracted you, sort of going against the grain, realizing that stigma.
Yeah, it really was. I think when you had spent time interviewing people in these really horrible conditions and realized they were there primarily because their problems were seen as a moral problem rather than a medical problem. And I think those of us who chose to work in that area, again, mostly people in recovery and some renegade professionals from other disciplines who came in to help sort of found modern addiction treatment, I think really said that it would probably take us a lifetime to counter that stigma. And as it turns out, it's taken most of that time to do just that.
Let me ask you, is there a sort of grand unified theory of addiction and recovery? Is there a single shared driver, cause, or characteristic for all addictive behaviors, whether it's drugs, gambling, sex addiction, etc.?
You know, Charles, there are multiple pathways of initiation into excessive drug use. Everything from genetic influences to physical pain to emotional trauma, psychiatric illness, family or relationship disturbances, conflicts, or just simply being in a drug-saturated peer group. But when you move from excessive drug use, which is that exposure required for addiction, and then move to the state of addiction, there's a point at which biology really takes over. And it takes over in the form of the inability to abstain from use, the loss of control over use, meaning once you begin, you can't predictably have control over a shutoff valve of that. And also you don't have control over the escalating consequences of that. So that neurobiology, these fundamental changes in the brain are really central to the addiction experience. And also conditions that must be reversed in the processes of remission and recovery. Interesting.
So in other words, while there are many pathways, to some extent, it is reducible to biology.
Yeah, I think there's addiction is a subset of a large pool of alcohol and drug-related use and a smaller pool of alcohol and drug-related problems. If you see it as a kind of a reverse triangle, and addiction is the point of the triangle at the bottom, that's part of this subset. Lots of things can create alcohol and drug use, including massive advertising by the alcohol, tobacco, and pharmaceutical industries.
Sure.
But it takes a particular set of vulnerabilities to move people into that addiction category and keep them there for prolonged addiction careers. And within that subset of people, no matter what the initiating causes are, what they come to share together in late stages of addiction is this neurobiological process, sometimes referred to as the hijacking of the brain.
This is perhaps a very broad question, but what are the telltale signs to watch for when evaluating a person for a substance abuse disorder?
Generally, we look at 4 categories of things in the assessment process. The first one is problem severity, and that severity is influenced by everything from a family history of alcohol and other drug problems, which keys us into some potential genetic vulnerabilities, speed of progression, age of onset of alcohol and drug use. As age of onset gets lower, the risk of developing a substance abuse disorder actually increases. Things like drug choices, all of those influence this factor of severity. And in terms of the diagnosis process, there are multiple symptoms used to diagnose a substance use disorder. And the number of those that people meet is an indicator of severity. The second area is problem complexity. And that really is the question of what are the obstacles to recovery, and are there additional problems that must be addressed in tandem with addiction recovery? And these would be things like co-occurring medical illness, pain management, for example, psychiatric illness. It would be environmental obstacles to recovery. Somebody's in a drug-saturated home environment, or somebody's homeless, or they're living in a community with virtually no recovery support resources. So we want to know not only how severe is the problem, but how complex is it? The third is problem chronicity. We simply want to know how long has this problem existed prior to engagement in the treatment process. And that gives us a little bit of an indication of how potentially intractable this problem may be. The final category we look at is recovery capital. And recovery capital are sort of like, what are the internal and external assets this person can draw on to initiate and sustain recovery over time? And the same for the family. What are the family resources that the family can draw on to support their recovery? So those four areas are generally what we look at. And for example, if you have very low problem severity and complexity and very high recovery capital, many of those individuals are going to resolve alcohol and drug problems on their own without professional treatment or without involvement in a recovery mutual aid group like AA or Smart Recovery or Narcotics Anonymous. However, if you have high problem severity and complexity and low recovery capital, this is an individual likely to need professional support for the recovery process and probably some prolonged peer-based recovery mutual aid involvement to support their recovery.
What are the 2 or 3 things that have changed since you began this work? This could be anything from significant changes in evaluation, treatment, acceptance.
Charles, it's hard to imagine the world that I started in when I look at the world of addiction treatment today. There was no NIAAA, no NIDA, no CSAT, no SAMHSA, no federal or state structures to speak of to oversee the development of a national network of addiction treatment in the 1960s. Today, we have that national network and an increasing network of recovery support services beyond treatment. We have science-guided treatments. We have virtually almost no science-guided treatments when I entered the field in the late 1960s. We have expanded recovery support resources such as recovery residences. We have recovery high schools and collegiate recovery programs. We have recovery community centers, recovery cafes, recovery ministry, recovery celebration events, and a renewal of workplace programs formerly referred to as employee assistance programs. So there's an elaborate network of support resources that exist today based on the work that's been done in this past half century. And at the same time, on the challenging side, we have drugs of much greater potency, particularly things like the fentanyl and fentanyl analogs that have driven the incredible overdose death rates that we've experienced particularly in the United States, but also globally. And we've also had increased availability of the psychoactive menu, if you will, has enlarged and become much more potent and much more dangerous in the years in which I've done this work.
Yeah, we started by talking about stigma. I know that has changed pretty significantly since you began your work.
Yeah, I think, if I had to picture it, I would say that we went from that really high level of stigma, and then as we moved into the late 70s and 80s, might have been sort of the high point of the medicalization, destigmatization, decriminalization of alcohol and drug problems. I mean, if somebody would have told me when I entered the field that in my lifetime I would see the wife of a president of the United States on television openly talking about her dependence on alcohol and other drugs, that would have been unthinkable for me. And yet we saw that with Mrs. Betty Ford and all kinds of celebrities coming forward and sort of breaking their silence on their recovery status in the late 70s into the 1980s. And then we began to get kind of not so much a backlash to that, but really in response to the cocaine epidemic and all the racism that got tied into that in the 1980s and early 1990s.
More specifically, I think it's the crack epidemic, yes?
Yes, the crack cocaine epidemic in particular, but also the broader intranasal ingestion of cocaine by predominantly white citizens of the United States. During that time, we saw a backlash and we saw an effort to re-stigmatize addiction, recriminalize it with draconian prison sentences during that time period, and also heightened stigma. So there was some retrenchment or regression in that destigmatization at that time. So since then, we had the rise of a new recovery advocacy movement in the late 1990s. And in the past 25 years, what we've seen are efforts to carry that movement to further medicalize, destigmatize, and decriminalize alcohol and drug problems since then. So it expresses our incredible ambivalence within this culture about our overall relationship with psychoactive drugs.
Bill, we hear over and again that addiction is a chronic medical condition, but it's extremely treatable. Are there, for lack of a better phrase, best practices in the approaches to take in treating people suffering from addiction?
Yeah, there are emerging best practices. We've historically treated addiction like it was a broken arm or a bacterial infection, with not only just brief episodes of treatment, but ever briefer treatment episodes, primarily due to the influence of managed care and the insurance industries. So what we've had is this beginning, middle, and an end of treatment in a very short period of time, and conveyed the expectation that people could now leave treatment with recovery now being self-sustainable on its own without professional guidance. And the point is, for the people with the most severe complex and the lowest recovery capital, that is simply not the case. So we're moving from those brief models to models of sustained recovery management nested in these larger recovery-oriented systems of care. And by systems, I don't mean treatment systems as much as how do we expand the recovery space or landscapes in local communities in which recovery from addiction can not just exist, but flourish. So it really changes community attitudes and community support systems beyond the treatment environment. So we're doing things like trying to reach people much earlier. We're trying to sustain support for them with things like post-treatment recovery checkups that are done, they're individualized, but they're they're done for a period. We know that recovery doesn't become fully stable until about 5 years of sustained recovery. So in that 5-year window, what we want to do is do checkups in the same way we would check up people with conditions like cancer or heart disease or diabetes, where we're constantly actively managing the ongoing recovery process. So I think if you think of this as stages of recovery, I think of it in terms of there's sort of a pre-recovery stage during active addiction where addiction is getting destabilized and the person is heightening their readiness for recovery, and then a period of recovery initiation, a third transition to recovery maintenance, a fourth enhanced quality of life in personal and family recovery, and fifth is breaking intergenerational cycles of addiction and related problems within families. So if you think of going from an acute model to the question, how do we support remission and recovery across these 5 long-term stages of personal and family recovery? That's what we're moving towards now.
So you've established these 5 stages of recovery. How do you measure the success of treatment?
Yeah, I think there are a number of really critical measures. Excuse me. I think the first of those is simply attraction. Can we have a treatment that voluntarily attracts the vast majority of people who are experiencing alcohol and drug problems? And can we attract them to that treatment at the earliest possible stages of problem development? What we know is the longer the duration of treatment prior to intervention, the greater the severity and chronicity and complexity of the problem at that point. So treatment outcomes improve as we intervene at earlier and earlier stages. So we want to attract people early. At present, only a small subset of people with alcohol and drug problems are engaged at that early stage. Most of the people we see in treatment are at middle to late stages of addiction.
Is there a particularly effective way of engaging these people, attracting these people at an early stage?
Yeah, there are a number of ways. One is destigmatizing those problems at a public level. So when we do sort of major anti-stigma campaigns in a community, people will begin to seek treatment at earlier stages in those communities. So there's sort of educational strategies, but I think by far one of the most powerful ways we do that is through a vanguard of people in recovery who sort of break their silence at a public level and talk about their status as a person in long-term recovery. And we also have a subset of those individuals I've described as recovery carriers, who think of it almost as if you think of epidemic disease, we often talk about patient zero, these persons who are super spreaders of disease. Well, imagine people who are super spreaders of health, and in this case, super spreaders of addiction recovery, who make recovery almost contagious by the quality of their lives and the quality of the stories that they share related to their own recovery experiences. So contact with people and families in recovery dramatically increases help-seeking behavior in local communities. So one of the strategies we're thinking about is how do we increase the density of recovery carriers within local communities? And that's one of the goals of local recovery advocacy organizations, is helping support this vanguard of people in recovery who come forward to share their stories at a local level. So a second strategy area is engagement and retention. Right now, only about half of people entering addiction treatment actually complete that treatment in the United States. So part of what we're doing is trying to figure out how do we dramatically increase the therapeutic alliance and engagement in treatment so we have a higher percentage of people, because what we know is people who complete treatment have higher odds of long-term post-treatment recovery than those that disengage from treatment early. And that is particularly the case with people in medication-assisted treatment. Third area is family engagement as a measure of treatment success. We know that when families are engaged in the treatment of an individual, that individual's odds of recovery go up. Right now, we still continue to be focused primarily on treating individuals, and we have a long way to go in terms of increasing rates of family and peer engagement in treatment. Another area is linkage to ongoing recovery support. How do we assertively link people who are in treatment to the kind of recovery support resources that are going to be needed to maintain recovery once that treatment experience has ended? And traditionally, that was referring people to either 12-step spiritual groups, secular alternatives to AA or NA, or religious recovery support mutual aid groups. Now we have this larger arena of recovery support institutions in local communities that we can also refer people to. Two other areas is increasing participation in continuing care. We know that post-treatment continuing care elevates long-term recovery outcomes. And we also know that in terms of evaluation that we measure remission and recovery outcomes post-treatment. The remission outcomes simply mean, does the person no longer meet criteria for a substance use disorder? Recovery, on the other hand, means not just that we're subtracting the problem, but what are we adding to this individual's life in terms of enhanced global health and social functioning and social contribution. So those are some of the cluster of areas that we use to measure treatment success.
Bill, let me ask, how has the emergence of digital tools affected some of these things, attraction?
Dramatically, it may be one of the positive side effects of the COVID epidemic is many of these support systems were forced to go virtually during the COVID epidemic. And as that epidemic subsided, we now have a very large, network of online recovery support resources. So I would say it's had a tremendous effect. And early on, we thought, well, these online recovery support meetings, for example, will simply be an adjunct to face-to-face meetings. But we now have people in long-term recovery who've never been to an in-person face-to-face recovery support meeting. They initiated their recovery online, and they now actively maintain that online. So there's a whole new set of technologies, internet-based technologies that are really emerging as new recovery support mechanisms.
And you are a proponent of such technologies.
Very much so. Yeah, very much so. And I'm a science guy, so I was really had all my thoughts about those on probation, pending the studies we were going to be doing. But the studies confirm their viability as both an adjunct to existing professional and peer support, but also in many cases an alternative to those resources.
Yeah. You mentioned the importance of family in recovery. What would be your recommendation to a family member who is in a household with a substance abuser?
Oh, that's interesting. I think there would probably be three primary lessons that I would share. I think the first of those is the importance of the family understanding they are essentially living with two people inside the addicted family member. There's an addicted person and a person seeking to escape addiction inside that same body. And at any moment, they have to figure out which one of those people they're talking to. And the challenge is, how do you support the person who's trying to escape addiction without actively supporting the addicted person? So it's almost like, how do you love both of these individuals, but not do behaviors that contribute and support active addiction, but support that fledgling self fighting to get free of addiction? And that's an enormously challenging task, and one that also benefits from professional guidance. And that relates to sort of a second lesson, which would be that everybody in an addicted family is in some ways held hostage to the addiction, meaning that there are dramatic physical and emotional effects on family members as a result of the addicted family member, and that the family itself and other individual members may need their own kind of recovery process, if you will, to escape the effects of this addiction. I think a third area is really just an affirmation that recovery is possible for more than half of individuals, even with the most severe of addictions, and that the odds of that person recovery will significantly increase if the family gets involved in the recovery process. So if you want to support that person in recovery, then by all means get involved with their life and their attempts at recovery.
Bill, what advice would you give the younger Bill White, and what would you say to people considering entering the field?
Oh, that's an interesting one too, Charles. I think I've asked myself at times, when we're in the whole arena of professional helpers, whether it's in social work, psychology, psychiatry, what is distinctive about working within the addictions arena? And I think there is one thing that's truly unique. In other areas of helping, you can fix a problem that people have and feel like you've been a part in that with them in partnership. But there are very few arenas where you can literally watch somebody transform their life, where there's a before and after line in the sand, where they virtually transform. And what I mean is the problem is simply not subtracted or minimized, but the fact that the person becomes somebody different. People who recover from addiction and go on to remarkable levels of achievement and social contribution, not in spite of addiction and recovery, but because of the strength they drew from that recovery process. So I think I would tell people that this is a field of endeavor that can be very challenging because of the losses you can experience. Let's be very clear. This is a potentially lethal disorder. So people who choose to work in this arena will experience losses. People they work with will die from this disorder. At the same time, people they work with will transform their lives and go on to remarkable levels of contribution. And to feel like you've been a part of that kind of transformation is truly a blessing of this special kind of ministry involved in this work. So I would welcome people, if they feel they're temperamentally suited for this kind of work, I would welcome them into this arena as a potentially deeply fulfilling occupation.
I was going to ask you a last question. What's the most rewarding aspect of your work? And I think you just answered that, Bill.
Yeah, I think if I was going, as a personal legacy, if I was going to leave anything, I think it would be the historical research I've done and all the writing I've done on the history of addiction treatment and recovery in the United States. A history, by the way, that was not available to me as I entered this field. I knew very little about the history of this field, and that literature was then not available, and today it is. So I think that contribution is very special to me. And I think I've also helped push the field from a focus in terms of its science on the pathology of addiction and the evaluation of brief treatment to a focus on the prevalence, pathways, styles, and stages of long-term recovery. I think a push towards this recovery focus of the field has been a very positive one that I've helped contribute to.
Yeah, well, you mentioned legacy, and that's precisely what Chestnut and Lighthouse Institute are looking to preserve in building the William White Library Repository of the more than 20,000 books, articles, and materials you've collected over these, 50 some odd years, Bill.
Yeah, I'm very honored by that and feel like that archive is sort of my gift to the future of the field, if you will. Indeed. Bill, I want to thank you on behalf of everyone at Chestnut, Lighthouse, people who are familiar with your work, people who are just learning about your work. I really do appreciate this conversation. As I said, I've been looking forward to it, as have some of my colleagues at the aforementioned Chestnut and Lighthouse. So this has been fun. Thanks so much. My pleasure, Charles.
Today I spoke with Bill White, Emeritus Senior Research Consultant at Chestnut Health Systems, Lighthouse Institute, a true giant in the field of addiction and recovery. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.